So we had a lot of questions, and what I tried to do is kind of put questions together and sort of themes to ask the group, because we only have about, I think, half an hour. But we'll go through a few of them, and we'll ask our fantastic expert panel here. And then we do have roaming microphones, so if there's like a burning follow-up question or a question that one of you want to ask in the audience, we'll leave a little time at the end for that. But again, I have like a lot of questions, so we're not going to get through everyone's. I apologize, but again, I tried to theme them. So I'm starting with this first one because it's actually the question that I get asked most in, not just in clinic, but actually out in the community, which is, why has the incidence of autism increased? And this question actually followed up with, is it because we're getting better at diagnosis? So I think this is just an important question to tackle up front. So I'm going to let any of you who would like to take that, maybe starting with Dan.
Well, I think we should, we can answer, that's a question that does come up every year. The answer is yes, improved diagnosis. I'm aware of at least 2 studies, and there are probably more now, where they used the current diagnostic rubric and went back in time and did retrospective review of records, and they find essentially the same prevalence that we have now. So now, it's a tough thing to be 100% certain because the denominator's been changing over time. In other words, it hasn't been measured the same way over time. But that's probably the best way to ask whether the prevalence of autism has been changing. And so, yes, it's changed, but it's changed because of better diagnosis, change in diagnostic rubric, et cetera. That's explaining most of that, the vast majority. It's not like there's some, new epidemic, although at some level, the more you recognize something, now the more, and we can do something about it, the more we can treat it. So, anything? Oh.
I agree with you, Dr. Geschwind, but I'll add 2 other influences which I think contribute to the rise in rates. One of these is the decrease in mortality of premature babies, which has actually undergone a remarkable change over the last 15 years. And we know that, unfortunately, these babies, the smallest of them, sometimes weighing only 1,000 grams, are subject to increased risk for essentially almost all of the neurodevelopmental disabilities, including ASD, cerebral palsy, intellectual disability. So that's one. I think that's reasonably well accepted by the medical community. The second, which is somewhat more controversial, relates to different types of in vitro fertilization and specifically certain types of manipulation of the egg and the embryo before implantation. Some studies suggest that some of those procedures may be associated with increased risk to the offspring.
We have to be very careful about that latter interpretation because there's no way to actually control those studies in many ways. So the issue is that those things, especially like perinatal problems and early, prematurity, are huge, have increased risk for autism. But as a percentage of the kind of diagnosis of autism, they can't account for a 100-fold increase, right, going from 1 in 2,000, 1 in 5,000 to 1 in 66 or 1 in 80. So in that big shift, that 2 orders of magnitude is mostly via, there are these other small things. Increasing age of parents, especially paternal age would add a little bit, but it's like less than 1% if you really play the numbers out. Each of these things is adding a small amount. But the key point is that these are biological things that we can identify that are true biomedical risk factors, and they're not necessarily a lot of the concerns that people have been worried about, like thimerosal or measles vaccine, right? Yeah.
Right. Okay, so along those lines, actually, there were a bunch of questions about prenatal testing for autism risk genes and whether we can do testing beyond the traditional, triple screen that we do and those sorts of things to look at copy number variation and even maybe single gene mutations. So I'm looking at Julian. He's already ready to answer.
Yeah.
It's so nice to have usually these are all the questions that I get asked in clinic, so it's really fun to have this panel
Sweat it out.
answering it. It's great.
So we have to be careful because now there are new technologies that are being offered to all pregnant women where you can actually take maternal blood and the cell-free DNA in it is being used to detect aneuploidy. So for example, the trisomies 21s, 1813s that we traditionally used to do amniocentesis and chorionic villus sampling for, now there are companies that offer the test where you just send the mom's blood and the fetus DNA is leaking into the maternal circulation and they're able to capture it, amplify it, and look at these kinds of copy number variations. It's getting to the point now that it's almost science fiction where they're able to look not only at missing neighborhoods, the copy number changes, but they're starting to now offer sequencing of specific genes in the maternal blood while you're pregnant. So the possibility, if there is a familial variant, right, that's already been identified in a previous sibling for doing that is coming down the road. The question is, should we offer sort of a more comprehensive test either during pregnancy or before? There are companies that offer carrier screening for mothers who are considering a pregnancy or who are currently pregnant. And that's primarily for recessive diseases to see if there's a genetic change. And if they find a mutation that's known to cause disease, it's a very limited test. It's looking for specific mutations that are known to cause disease. Then you can look at the partner and then plan the future pregnancy during preconception or during the pregnancy. But offering a sort of broad genomic technology like exome, for example, during a pregnancy is still ethically being discussed. Just because a lot of the time the result that we get has a lot of uncertainty, and that uncertainty being used for making determinations about continuing on a pregnancy or planning one has its own ethical concerns. So we're not quite there yet, although we do offer microarrays prenatally, particularly in the setting of fetal abnormalities, right, in congenital defects. I don't think we're there yet when we don't know a priori what to look for, meaning there's a familial genetic variant already identified, to offer any kind of testing that's more broad and comprehensive.
So while
is that test available for a pregnant mother?
So it's offered actually in the first trimester. So as late first trimester, you can get your blood drawn and check. Yeah.
So while you have the microphone, I'm going to ask one more question about clinical genetics, and then we'll move on to the folks at the other end of the table. There's a lot of questions asked about just the pragmatics of obtaining genetic testing for a child with autism. So new diagnosis of autism, what do we do next in terms of what is the testing, but then also, what is the process around getting insurance coverage, which I think is a really important question that we try to tackle in that multidisciplinary clinic, but I wondered if you could quickly summarize that process.
Right. So the standard protocol is that we traditionally, if they're male, offer Fragile X testing, which is a specific test because it's the only way that you can identify the expansion of the trinucleotide repeats. A microarray as a first-tier test. And then if that's normal, in the absence of some obvious physical signs that lead us in one specific gene or not, let's say extreme macrocephaly P10 sequencing, then you move to a more broad technology like exome sequencing. And that's the approach that we use at UCLA. The guidelines are still lagging behind as a standard of care to do that, but we're all moving in that direction. The field is moving in that direction. There are challenges with insurance because Fragile X has been a well-established test for identifying early intellectual disability or autism in boys, right, as a potential cause, both of its frequency and because it's a well-known established condition for more than 25 years. But the problem is that all these new technologies, when they're first implemented, are considered experimental until we have enough data suggesting that in the clinical realm, they actually make a significant difference. So eventually microarrays, after almost 15 years in clinical practice, they became standard of care, right? So now most companies, I'm saying most, not all, feel comfortable proceeding with that test. But when you get to things like exome sequencing, there's a lot of pushback because they feel like it's still experimental. And each policy is different. So you cannot assume that because you have one type of insurance versus another, that it will always be the rule that they will cover it or not. So tread lightly. That means that you have to really do your due diligence and help families out and really let them know these are the codes for the tests. And you have to really check if the particular policy that the patient has will cover it, because otherwise, I showed you the types of sticker shocks that they'll get when they get the bill back from either the laboratory or the clinical system that they're participating in. So yeah, I mean, that's also a barrier to access. This is something that we struggle in our clinic and in care in general, that we wish that most people had access to this technology because they will get a diagnosis in a significant proportion of cases, but insurance policies, and even when you are in just state-funded healthcare systems, there's a hesitation to pay for them. So there's a disproportionate number of people who really have poor access to care to begin with, who are also being denied the opportunity to be evaluated. So,
Just to add one thing, that these tests aren't maybe aren't reimbursed by every company, but they're part of the American College of Medical Genetics guidelines, so that if one has a little bit of energy, one can, obviously, we often have to go back and forth. Our genetic counselors here spend a lot of time going back and forth to get authorization for these things because they are clinically indicated. And so, but does that make sense?
So there were many, many questions about adults who are minimally verbal. Or who have comorbid intellectual disability, and what services and offerings do we have for them, and what can we do? So I've actually, the question is first for Jim and then for the group down there. For Jim, there were a couple questions about psychopharmacology in adults who are minimally verbal, particularly around aggression or behavioral issues in adults. Do you have any specific recommendations or thoughts around management? So we'll actually start with that, and then we'll go to behavioral.
Well, first off, it's important to fess up that our knowledge, our number of studies of adults on the spectrum and their response to medications is woefully thin relative to children and adolescents, where it could be a lot better. That said, there are enough suggestions that adults overall tend to respond similarly to the same medications that have been relatively well tested in children. So, for example, there have been some studies of adults with irritability, aggression, self-injurious behavior, and the antipsychotics that Dr. Schneider talked about, like risperidone or aripiprazole, also appear to be effective. And likewise, diagnostically, we would look for a similar array of possible co-occurring problems that themselves are very important to treat, like anxiety, depression. These things are even more common in adults, of course, and they're often overlooked, especially in minimally verbal individuals. And so we pay as much attention and care as we can when working and evaluating such an individual to make sure we didn't miss something like that, which is often very treatable. I'll give you an example. A rule of thumb in seeing an adult who's minimally verbal, who by observation has gone through a rather abrupt regression or deterioration in functioning, the first things that we think about are, is this individual depressed, or have they developed a new anxiety disorder? I mean, that and then the possibility of the influence of an acute stressor or trauma, that probably covers 3/4 of that kind of presentation. Now, I'll mention one last thing, which is that there's an odd finding that is not strong enough yet to make a definitive statement, but it looks like it's possible that adults on the spectrum may be more responsive to some of the treatments that we've tested in kids that haven't really been that effective, particularly antidepressants for anxiety, repetitive behaviors. It's just been a couple of studies, but they have seemed to work better in adults for reasons that we cannot explain than they did in kids. So that's where we're at. Similar approach overall, really.
And one thing quickly I would add to that from a medication standpoint is so we see on the MD side of our clinic, we do see adults also. I mean, this week in my clinic, every patient of mine was over the age of 20, and I'm a pediatric neurologist. And the reason is that there isn't often a place for these patients to go once they reach adulthood, and we can take care of them because we can see adults and children as well. But one of the biggest challenges from a psychopharm standpoint is that oftentimes patients have been taking certain medications for sometimes decades, and they've just been left on, and the new ones have been added and added and added because they're seeing different providers. And so they often will come to us taking a list of medications, and it's not entirely clear anymore what those are indicated for. And so one thing I always encourage parents to do, if possible, before going to a new consultant, is to try to get some kind of a tracking sheet of not just the list of the meds and the doses, but the dates that they were started and maybe why they were started. Because oftentimes what we do first is start peeling things away, because sometimes the symptoms that we're seeing are actually just side effects from just chronic medication overuse that's really never had kind of that big picture look. And sometimes we see that when we just peel away a lot of the medications, some of the symptoms that we are worried about improve. So just one thing that I would add to that, that from a clinical standpoint. But yeah, and so then the question is, from a behavioral intervention standpoint, are there programs for adults like this? And
Right. And of course, we all know that there aren't many programs, and that's why the question is probably being asked. And so, I'm taking the lens of kind of a clinician at the CAN clinic and knowing the overwhelming need to service our adult population. And in general, what we can say is that, even though there haven't been a lot of trials with kind of minimally verbal or lower functioning in adults, there's kind of an understanding that the same basic behavioral treatment principles should apply if you're taking a developmental framework. So, for example, if we have a minimally verbal adult, there's no reason why we couldn't give them access to this multimodal communication system. Many adults don't have a way to communicate, and so there's no reason to suggest that we couldn't do something like an AAC with those adults. So we've been doing kind of focused consultations in the clinic around that, trying to give our adult population some more access to meaningful functional communication. In addition, I'll just say that there's been a trend, of course, a shift to really think about, what's going to happen once these individuals age out of the school system. And whose responsibility is it? Regional center, other centers, and there's some wonderful groups, if anyone wants to come talk to me after, that are starting to think about employment for individuals on the spectrum and job training, and kind of with a vocational kind of flair to them. And also programs that are kind of very intensive to get individuals who are even a bit lower functioning or having difficulty communicating ready for more gainful employment opportunities. Because at that point, we need to understand what's going to boost their quality of life, right? So what about thinking about well-being and thinking about having them contribute meaningfully in the society? So the focus shifts a bit to those areas.
Mm-hmm. Alrighty, a couple questions for Liz. I'm sure you get asked this one often as well, which is, you have peers for preschoolers and you have peers for adolescents and adults. What about the school-age kids?
So Peers was originally developed at UCLA, really modeled after a program that came before called Children's Friendship Training. Is this even working?
Not even on, I don't think.
Okay. So Children's, yeah, be better, thanks. Children's Friendship Training actually was developed also here at UCLA by Dr. Fred Frankel and Bob Myatt. And so it's an elementary school aged program. So it's being done. It's an evidence-based treatment. It's not even just evidence-based for kids on the autism spectrum, but it's also been found to be effective for kids with ADHD, with fetal alcohol spectrum spectrum disorder, OCD, and other anxiety disorders. It's a very, very good program. If you want more information about that, you would contact the UCLA Children's and, it's Parenting and Children's Friendship Training Program, and it's directed by Cynthia Whittam. So it's not that it's gone unnoticed, it's just that most of the social skills interventions that are out there are focused on elementary school age children already. We're trying to fill gaps in evidence-based treatments. And that's where we started with adolescents, we moved on to adults, we're working with preschoolers, and now we're also taking on these new areas of employment. With Dr. Amanda Gulsrud and I and Jim McCracken, we're doing this college to career transition program, and we're also going to be focusing more on romantic relationships and other types of social skills. So it's not that we don't value that time of development, it's just it's being done and there are evidence-based treatments already.
Mm-hmm. Another question for you, I thought this was a great one, is how would you facilitate a young adult to get involved in peers? So I think it's the idea is that if there's someone that they know or maybe a family member who would benefit from peers, like how are there strategies to sort of think about getting them involved?
So one of the things that's very important, I think, about teaching social skills to people on the spectrum is that they should want to learn the skills, that they should be socially motivated. I think with younger children, you can kind of, force them to do things and or bribe them, or we would call them rewards and reinforcers, but you know what I'm talking about. But with once they hit adolescence, they have to be intrinsically motivated to want to learn these skills. And it's not even just that it doesn't work if they're not socially motivated, but I'm not even sure it's ethical to force social skills onto someone. So that's where we start, is are they even socially motivated to learn these skills related to making and keeping friends? And if they are, we have to assess for other things like their social anxiety. Are they able to tolerate being in a group setting, which is how we typically run our programs? Or do we need to work on that anxiety first? What's the treatment priority? Are they behaviorally and emotionally regulated? Certainly, throwing chairs and having outbursts is going to affect your ability to make and keep friends, but I would say that's a higher treatment priority. And then also thinking about things like cognitive and language abilities. Are they able to follow the program? This is a very high-paced, sort of really, intense program. It's only 16 weeks in length, and we cover a lot of material really quickly. Are they going to be able to really benefit from that? Or do we need to get them additional resources through the Child and Adult Neurodevelopmental Clinic, where we can do this on an individual basis and kind of slow things down? And it's all about really tailoring the treatment for this person and making sure that it's a good fit. So those are some of the questions that we would ask initially. Does that answer the question, I hope?
Yes.
Okay.
Okay, so another behavioral intervention question, and then we'll go back to some of the biology questions. I thought this was a great one too. So if there's a lot of improvement after a child receives ABA, is it typically discontinued and then resumed only if there's a need? So the question around, how do you sustain treatment if you see gain, which I think is something that we unfortunately see happen from a services standpoint, but
well, what I'll say is, that we don't have a lot of data about this, but if you just think of the developmental trajectory of a young child, you tend to get more ABA before school, right? Before school age, so that kind of intensive early intervention period. And then when children transition to school age, the school takes care of their educational needs. And so we may see a decrease in ABA hours as a function of that, because the individual now has to make it up at other times. Do they still need the ABA past those years? It depends on the child, right? So we know that some children really benefit in the short term from intensive ABA, and then they're ready to enter into the school setting, and they're doing fairly well in that setting, and they may need some additional hours after school, but maybe not the intensity they once had. And we see that fairly often. And of course, we can't usually fit. If you're a 3-year-old getting 25 to 30 hours of ABA and you get into the school, well, now you're 25 to 30 hours at school. And so where are you going to fit your ABA in? So there's kind of a natural decrease in ABA as the child gets older. And as long as the child is still meeting those milestones, that's just fine. But if they're not, and we look at treatment targets and we look at 2 to 3 months, right, intervals, children should be making meaningful gains in 2 to 3 months on all of their targets. And if they're not, then the method, the mode that we're teaching, something needs to change. Either the target's not right, the way that we're teaching the child is not correct, the setting is inappropriate. We need to evaluate all of that.
Okay, oh, go ahead.
The quick comment to add to that, I get asked that question a lot in clinic from families, and I think what happens sometimes is, as Dr. Gulsrud was saying, we get this intensive early intervention. Kids are doing really well. Everyone feels like, great, they're ready to go to, an inclusion kindergarten program. Things are looking good, and parents come and ask me, does that mean we're done with treatment? And what I usually tell people is, maybe we are for now. They're doing really well. They're being successful, and let's keep watching. And as the social demands of their environment change, we're talking about a, fundamentally social communication-based disorder. They may be doing really well in kindergarten, first, second grade. As they get a little bit older and the social demands change and increase, that might be a good point to stop and think, okay, now are they still keeping up with these new demands? This might be a time to restart some type of intervention.
I think I want to just piggyback off that because you make such a good point that with social skills training, I know this question was about ABA, but it's the same thing. You put a kid in a social skills group when they're in preschool and they do really well, you're not done. The social demands are going to change. And really there's these developmental periods that are really critical. I would say preschool social skills, for example, are quite different than once you hit elementary school. You need kind of a new set of skills. Parents need to know how to organize play dates. Middle school. Now it's not about play, it's about having conversation, so you need to keep up with that social demand. And then on to adulthood, there's employment. So I think it's true with ABA, I think it's true with most types of treatment, so you're probably going to need tune-ups across development. But I'm not sure that they have to be, indefinitely in treatment either.
Okay, I'm going to do a couple more, and then I'm going to open it up, because I think we have until 5:10, is that right, until Dan makes closing remarks? Okay, so we'll give everyone 10 minutes for open questions. So this is also a question I think we get asked a lot. It's a good one to talk about with the group, which is maybe for Jim or Dan, is there a correlation between maternal medication use, particularly antidepressants and anti-anxiety medications, and autism risk?
Well, there are a small number of medications that have clearly been associated with an increase in autism risk. Valproic acid or Depakote exposure in utero is well known as a major offender in that regard. But in actual fact, if you look at these other commonly prescribed medicines like SSRIs, as Dr. Geschwind was saying earlier, first of all, the results of those studies are just terribly mixed. But even beyond that, those that do suggest that they form a risk for the fetus really only are describing a very, very small increase in risk that would translate to just maybe a couple of percentage points of the overall risk or the overall population increase of those exposed. So it's something that is definitely in need of more research, and some of the work that Dr. Geschwind has been doing with these very, very large national databases like in the Netherlands are likely to be able to point us perhaps towards more definitive linkages between intrauterine exposures and ASD risk. I'll throw out one little teaser for you as well, though. There is a number of scientists who believe that maternal infection during pregnancy may increase risk for autism as well.
Mm-hmm.
Yeah, so I have to debunk both of those things. That's unfortunately, but
we have great conversations at work.
This is good. Next year we'll do panels.
So what Jim was saying is totally correct. So I'm not actually, is that there are scientists who believe that. The maternal infection in animal models like rats and mice shows clear neurodevelopmental outcomes later in life. So you can have infections early on. It's not even infection, it's inflammation early in certain first and second trimester in rats and mice can lead to later behavioral changes in the offspring. That's been shown, that's in animals. They're very big issues with some of that, which can also be, anyway, there are a lot of, but there is no relationship of that to autism. And I'm happy to discuss that afterwards. I don't want to take up, it would take 5 minutes to explain why that is, but it's much more plausible in schizophrenia, actually, where there actually is substantial evidence for a maternal shared environmental effect. That means if, something going on in the womb. When people are womb mates, like twins, they're even if they're not identical twins, their risk of sharing schizophrenia goes way, way up compared to regular siblings who have the same genetic matching. Not so in autism. So that's a kind of a controversial claim, but there's no evidence for it in autism. But it doesn't, but let's just move away from autism for a second. Many of us, autism is something that we've labeled, but in terms of the potential for such things to cause some neurodevelopmental outcome, whether it be schizophrenia or developmental delay, it's definitely there. With the SSRIs, there's a huge confound, and the studies that have actually been done in Scandinavia, which are the largest and most unbiased, when they control for maternal, so it's very complicated, because everybody who's taking an SSRI while they're pregnant, 99%, are taking it for a reason, and it's usually a singular reason, which is depression. And so you can look at moms who were depressed during pregnancy and took it, have a history of depression, who took it before but didn't take it during pregnancy, but had a history, right? There are all kinds of ways to control for that at a population level. And when you do, you basically get no effect. So now, why would that be? Like a mom, with depression, why is it more likely? And again, what Dr. McCracken said is totally right. There's a tiny, tiny increase. The increase in risk goes from like 1% to 1.1%. I mean, it's significant over the entire population in, let's say, Sweden, but it has no practical thing, because if you're a mom who's like severely depressed, you should take the SSRI, because it's the depression that's having the larger effect anyway. Now, one of the, and has a huge impact on your quality of life, and that would be the recommendation today, right? If it's a severe depression, obviously not for anything minor. You don't want to take anything during pregnancy, just to, but the the more global issue is like, why does increase in depression in a mom lead to kind of increased risk for autism? And there are multiple reasons. One of them, though, is that there is a slight sharing of the genetic risk for depression and autism, just like there is for autism and schizophrenia. Slight increase. So it could be that that's actually a genetic thing, that the mom's genetic predisposition towards depression, coupled with whatever else is coming from dad, going to the child with autism, increases the risk a little bit. But again, it is very, very small. Nothing nearly as large as birth complications or prematurity, like Dr. McCracken mentioned before.
And I just want to close by making a quick comment. Most of the counseling sessions that I do for genetic testing usually involve questions from mothers who come in with a significant amount of anxiety and guilt about what might have happened during the pregnancy that might have contributed to what happened to their child. And I really emphasize lifting that burden at that very moment, because the weight that actually, the liberation that creates moves me every time that I have a clinic visit, where I see how hearing someone tell you that there's nothing that you could have done or that you did. It wasn't the evil eye, it wasn't the face of the moon, it wasn't that you fell, it wasn't what you took or you didn't take, it wasn't the infection or whatever else they're telling you that caused that, okay? And that can go a long way to finding a journey, finding an actual answer, right? And bringing it all together and lifting what I feel is what I constantly see in my practice, which is this what if.
Yeah, that's really important. So we have 10 minutes. I have lots more questions here, but I actually thought it might be good to open it up to the audience in case there were questions that you still had, or even ones that you put on a note card that I haven't gotten to yet that you really want answered. Yes, can you? Oh, and then she has a microphone way on the other side.
Sorry. Come on. Okay, can you hear me okay? So my question was, I think it was on one of the cards, it was about an article that was in LA Parent Magazine this month, and it was talking about cerebral fluid in utero for the babies and the structures. And so if there was an excess of fluid during the pregnancy, that it could result in autism diagnosis. I don't remember exactly what the doctor's name was, but it was in this magazine this month. Have you guys ever heard anything about cerebral fluid or the brainstem fluid possibly resulting in an ASD diagnosis?
You could, Susan, you could comment on the the CSF.
Yes, I'm pretty sure that is a study that was done by the North Carolina group, showing that the amount of CSF in the brains of babies, they actually wasn't prenatally, it was, I believe, 6 months of age, was correlated with an ASD diagnosis, and that they could separate out what children were at high risk for developing autism and ultimately developed autism later at 6 months of age based on the amount of cerebrospinal fluid in the brain. And that's not to suggest that there was any kind of accident or anything like that that occurred in the brain, but that there are a number of brain findings that are correlated with autism. We talked about several of them today, and having an excess of cerebrospinal fluid is one of them. We don't know why. We don't know if they've lost neurons or if it's just part of having a big head, or we don't know. It's not a specific finding, but it is one of many, many brain differences that we see in individuals who do end up with autism. But it's not an accident. It's not like mom fell and the baby's brain got fluid.
Mm-hmm. Right. That's work actually is part of that IBIS network that Susan talked about earlier. So, someone's right behind you, right there. Okay, yeah.
Hi, do you see any benefit to doing genetic testing on an adult with autism, like an 18-year-old that's nonverbal and has been nonverbal his entire life? Have you seen any benefit from that?
That's a great question.
So that's a question that we struggle with, not only with our colleagues, but also with insurance companies justifying it, right? And why it's medically necessary to explore that possibility. I always say that regardless of where you are in your journey, and particularly when you are 30, 40 years old, and you haven't had an opportunity to figure out exactly the cause of the patient's symptoms, it actually has more meaning in terms of ending that diagnostic journey at that point, identifying what the cause is, and having a context for all of the things that you've gone through that are put in a perspective. And I think that's something that is intangible and difficult to quantify, to justify others, and how powerful and meaningful that is for many families. And there are circumstances in which specific genetic conditions will have manifestations much later in life, and knowing at any point during that journey may actually be relevant, whether it's tremors and early onset Alzheimer's down the road or anything like that, right? So I think at any point during the journey, there will be, depending on the genetic etiology, some benefit to knowing what it is. Yeah.
Yeah, I just want to say ditto.
So how would you find
So the logistics of seeking that out is not trivial, right? Because you can self-refer, right? And you can go to places like the Can Clinic. I mean, I think I encourage you to make sure that when you seek genetic testing, that you have had some formal developmental evaluation and someone has provided you with the proper diagnosis, right? We don't want to see anyone who's nonverbal because there are many reasons for that, right? And I think if you've actually been through a physician, whether it's a neurologist or a specialist that has actually been able to define what the concerns are and has ruled out other potential causes, right? Then I think the referral to genetics is more appropriate, right? There are many reasons why you could be nonverbal and have that presentation later on.
I have a follow-up for you, Julian. What about the parent who says, well, I'll go through 23andMe or Ancestry.com. Would that have any medical value?
See,
Don't
this
get him
is-
started.
This is Dr. McCracken, exactly. Shafali knows this too. He knows how to push my buttons.
You've heard
So,
you've heard that before,
We
right?
planted
no,
that
no.
question over there.
so unfortunately, this opens a kind of worms that I'm happy to open. So, because it extends to things that we think are benign, but I think are actually leading families in directions that I think are unproductive. And I'm always supportive, but I'm trying to be a little bit directive, because some things are really going to take you down journeys that are not the best. So 23andMe and Ancestry and all those things, and again, I'm just using that because it was already mentioned. I have no interest in those companies or what they do, as you can tell. They are actually, and they have disclaimers at the bottom or in very small letters that they tell you that this is for entertainment purposes only. This is so that you can find out that you have a quarter Jewish and you didn't know, or that you actually were of some particular ancestry. And in some rare situations, they may or may not provide you variants that may be relevant to increasing your risk of diabetes or something like that by a factor of 2, 3, or 4, which as a disease causing, again, Dr. Geschwind very eloquently presented it to you this morning, right? That these are things that may contribute, but not necessarily directly cause, right? So I think as an experiment in perhaps motivating you to change your lifestyle in terms of understanding your relationships, a lot of people have found long-lost family members that didn't know. They may find out that their father's not their father. I mean, things like that. Then you can entertain that possibility, right? But I think as a tool for diagnosis, they're not intended to be that. And if you read the small lettering, it clearly states this is not for diagnostic purposes. But then that brings me to another thing. The latest thing that I get is people that refer to me because they've had variant analysis for MTHFR, which is a common change in the population that 10, 15, 20% of people are walking around with these polymorphic changes that Dr. Geschwind described. These are changes that we all have in our DNA that just make us different, but that don't necessarily are associated with any increased risk of anything, let alone that autism. And there's a huge community out there that's very invested because there are potential supplements that you could take that may increase your folate in your body and perhaps enhance folate metabolism. And again, this is another one of those in the list where if you really are careful about dissecting the literature, there really is no association between the two. So I think I would add that to the same kind of story.
How many of you all in the audience either have yourself, family member, or a friend who's had one of these commercial genotyping tests run? Wow.
My follow-up question is, how many of you would be willing to, in an anonymized way, share that with the, let's say UCLA, whoever your healthcare provider was, just share it with them, anonymized? Yeah, 23andMe or Ancestry. So 1 in 10, yeah. Well, no, the reason I'm asking is because there's quite a lot of population level research that one can do with that data. That's why that's 23andMe's business model. Of course, we don't have a business model, but we're beginning to connect our patients' medical records in an anonymized way as a whole group with genetic data so that we can make, improve healthcare delivery. That's that precision health thing I was talking about. So the idea is, would you share that?
Share it for good, not
Yeah. Well, that's up to you to decide. But for research, if there were research projects going on, one of the things we're doing now is we're going to genotype 150,000 patients using a system very similar to, let's say, what 23andMe does, and we're doing that in 150,000 patients across the health system to see if we can gain insights on how to prevent postoperative complications in certain patients, identify those at risk for X, Y, and Z, medical complications to improve care. But it dawned on us at one point, and since Dr. McCracken asked this, I'm sorry to derail this from autism. We'll add 4 or 5 minutes back. Because that a huge percentage of the patients might have had this done already, and the data's already out there. So rather than redoing it on your blood for research, how many people would share that information in an anonymized way? So it wouldn't be connected to Yeah, let's raise your, I'm just curious. Yeah, it's a lot. Thank you.
Yeah. Okay, there's one back
Meet me out
there.
there afterwards. Just kidding.
One back there, a question back there.
Most patients with autism, they pass the brain auditory evoke response, but in real life they don't seem to hear us. So my question is this test, the brain auditory evoke response, enough to rule out a hearing deficiency?
Well,
Right, I mean, there's many levels of, essentially, there's many levels at which one can have hearing deficits, and that test at birth is really looking at whether the brain responds to sound. But we certainly can do different levels of testing to see if there's actually like peripheral hearing issues. Many times though, and I actually find often that kids are getting really complex auditory evoked potentials and other kinds of audiology evaluations to look for hearing issues, when in fact, the hearing system is okay. The issue is in processing of language and receptive language. And it is an area of interest. Are there deficits in kind of processing of language, even at kind of a lower level, that might relate to some of the language deficits? And actually that's something that Dr. DeStefano here, during her postdoc in my lab, had a grant from Autism Speaks that's just finishing to look at this using EEG to see how does the brain respond to and process language, essentially, because there may be some deficits at that higher level. But again, there haven't been studies that have shown that there's actually low level, like brainstem auditory processing problems in children with autism.
yeah, think of the hearing as a kind of first stage in the processing of language, at one level. I mean, it's some oversimplification. But, and the bear is testing everything, multiple, it's like a relay, and it's testing is there delay at various points in this relay all the way up to the cerebral cortex. And so it's really unusual, unless there are other signs, for the bear to be abnormal, actually in autism per se, and the hearing deficits that are occurring, or what is lack of responsiveness to language, isn't a primary hearing deficit in most cases. So, yeah.
I just wanted to add a couple of things. One is that some imaging studies quite a while back have shown that there was reduced responses in the brain in areas that we call voice selective. So there are some brain regions in the temporal lobe that in neurotypical individuals seems to really be maximally engaged or activated by speech, human speech, and those regions did not seem to be quite as active, even in high-functioning individuals that could undergo the kind of studies. And the second one is, in our lab, we have been doing a lot of work on social on overt responsivity to different stimuli, which include also auditory stimuli. So if you think about some individuals who may find most stimuli in the auditory modality aversive, they may have learned to kind of like suppress or tone down those responses, and it may be generalized to all type of stimuli. So both of these factors can contribute to seemingly lack of response, even if there is nothing wrong at the level of being able to detect sounds as tested by evoked potential.
Yeah. I mean, just to end as a neurologist, the bear is testing that kind of hearing reflex. If that's normal, and it's usually done in very young kids who aren't responding, but if that's normal in an adult or a kid, there's no need to go on. If the person's totally unresponsive, somebody could have a high frequency hearing loss, as happens with aging, right? And that's not going to be picked up with a bear or something like that. But that's a different kind of, person will still respond to language.
Mm-hmm. Okay, it's 5:15, so we've held you over for 5 minutes. I think, Dan, do you want to make any, you're scheduled to give closing remarks.
I'm going to keep the closing remarks extremely brief so that those of you who do want to stay can ask us questions up to our faces, and that those of you who want to leave can, because we realize it can take a long time to get home, depending on where you're from, in this traffic. And we take no responsibility for the traffic. But we want to thank you very much, especially all of you who've been stalwart and stayed to the end and asked such great and interesting questions and even sparked some controversy and interest among us. So thank you again for coming and for being here with us. Please fill out all the paperwork and stuff, and we'll hang around a few minutes in case there are questions that haven't been answered. Thank you.